Hi, it's Dr. Centeno, and thanks so much for joining us today. Got an interesting topic. We're going to be talking a little bit about styloidectomy, and this is one that comes up an awful lot. Patients are concerned about compression of the internal jugular vein by a styloid process after usually a CT scan or an X-ray is done. And they would like to get the styloid process removed in a surgery called the styloidectomy. Now, many of those patients, as I come in contact with them, have craniocervical instability. And so all of a sudden now we've got sort of two things going on, right? We've got this presumably long styloid that needs to come out, and at the same time, the person's got craniocervical instability. So what's going on with all of that? What is a styloidectomy? What's it being done for? How does it really interact with craniocervical instability? Why is the timing of these procedures or these treatments important? So we're going to get into all of that today. As usual, we'll start with a short presentation and then go to Q&A. If you've got questions, just go ahead and put them in the comments wherever you are, whether you're on Facebook or on YouTube, and I'll see them here. The sooner you get those questions in, the more likely they are to be answered, because we get a lot of questions during this broadcast. So again, the questions are answered in the order in which I receive them. And so try to get your questions in now or early, or as things come up for you and you watch the information. So again, we're going to be getting into styloidectomy. And what is that? What's it done for? How does it interact with craniocervical instability? Why is this such a big deal? Why do I get asked about it all the time? And we'll get started here in just a second. We'll let a few more people come on. Just as an update for everybody, I've spent the better part of the morning and a chunk of yesterday going through some of the data that's going to be part of an upcoming publication on craniocervical instability. And because of the type of granular information we collected on these patients, I can test lots and lots of different hypotheses. Not only does hypermobility make a difference, do specific symptoms make a difference, do specific symptom clusters make a difference with regard to outcome. Lots of different things can be tested that way. And so it's been fascinating 2 days. I've got probably another couple hours to put into it today, and then I'll turn it back over to the research team. Usually what happens here is I mess with the data, try to draw some conclusions from it, and the research team then independently looks at it and tries to make sure that we're both in agreement as to what it is we're seeing. So we'll get started then on the presentation here. Why does a styloidectomy cause instability in CCI patients? So let's get into that topic. So the anatomy, some of the things to know is that you've got the styloid process, and that's actually connected to a ligament that then connects to the hyoid. And this hyoid is a little muscle that lives way up in here. And that hyoid is really a free-floating muscle that's connected really only by other muscles, meaning it doesn't have a direct connection into the skull other than through this stylohyoid ligament. Now, when we say someone needs a styloidectomy, what we see basically is not that the styloid is long, really, although that's the common conception, but it's that the stylohyoid ligament, meaning the ligament between the styloid process and the hyoid down here, has calcified. So the ligament looks long, but it's really not. And then there's a muscle that connects here, the stylohyoid muscle, that again goes between those two. So realize that if we go to try to take out the styloid, we're going to remove that muscle. we're going to remove that ligament. And that's a key ligament that's connecting certain things up here. And we'll talk a little bit about that in a second. So why is this being done? Let's get into this a little bit. What is Eagle syndrome? Because that's the most common reason a styloidectomy is performed. So what is Eagle syndrome? Basically, the concept is that someone has an elongated styloid, or really, again, as we said, calcification of that stylohyoid ligament. And that can cause compression of the internal jugular vein, the 12th, 9th, and vagus nerves between the styloid and basically the transverse process of C1. Now, since this involves C1, you might imagine that if you have craniocervical instability and your C1 is unstable, then that's also going to cause part of the problem, right? That just makes sense. Now, the problem is that there's a lot of overlap. Let me get back here, guys. That there's a lot of overlap between these problems. So we have CCI patients who have more dizziness, numbness, tingling, visual issues, brain fog, GI symptoms, etc. And then we've got Eagle patients that tend to have more kind of throat issues. And then there's overlap between these two. The CCI patients tend to have neck pain. Some of the Eagle patients tend to have neck pain, tinnitus, which can be from internal jugular vein compression, headache, dizziness, pain with turning the head, etc. So as we look at these two things, there's quite a bit of overlap between the symptoms of these two problems, which is really where we start to run into issues. Now, the biggest problem is that really elongated styloids are pretty common, right? If we were to take 100 people off the street, somewhere between 4 to 7 of them who are living a normal life of no problems at all would have a long styloid. And then only about 4% of those patients who actually would have symptoms, right? So that means that we'd not have to take 100 people off the street and find 4 to 7 with elongated styloids. We probably wouldn't find a single one of them who had Eagle syndrome. We'd have to take hundreds and hundreds of people off the street to find one patient with elongated styloid where that elongated styloid was actually causing a problem. So again, think about that one for a second. Asymptomatic, meaning elongated styloids that produce no symptoms, are the rule and not the exception. The exception is when elongated styloids cause symptoms. So very important. And this is important because we see all the time that patients basically get an X-ray or CT scan. Someone says, aha, there's elongated styloids. And you've got all these symptoms. You must be in this Eagle syndrome classification. The problem is, as we've already looked at, that craniocervical instability produces very similar symptoms. So basically, you could take a CCI patient, claim they have Eagle syndrome, but they really don't because their symptoms are being caused by the CCI and not the styloid. In fact, it's more likely that their symptoms are caused by the CCI and not the styloid. So what is a styloidectomy? Well, the styloid is, I'm going to have to do this again, guys, but this is how I get this back. The styloid is right there. It's usually done as an open surgery. Sometimes it can be done endoscopically, but it's basically removal of that calcified portion of the stylohyoid ligament. And also sometimes there's shaving down of the C1 transverse process. Now, let's look at the biomechanics of this area because it's very, very important to this conversation. You see the hyoid bone in the middle there, and then you see it's basically suspended by muscles and that stylohyoid ligament. And then all of that anchors down into the chest. So this is all part of this anterior stabilization syndrome. So what's the key biomechanical roles of the stylohyoid ligament? Obviously, suspension and positional control of the hyoid, force transmission within the styloid apparatus, and dynamic stabilization during motion. As you can see, this allows coordinated motion between the jaw, the tongue, the larynx, and the upper cervical spine. So again, we have direct evidence in the literature that the stylohyoid ligament that we're removing in a styloidectomy is directly responsible for stabilization functions within the upper neck. Now, if you already had upper neck instability, the last thing we would want to do is obviously get rid of that ligament, because then that's going to cause more instability. Again, hence cutting out the stylohyoid ligament will make the upper cervical stability worse, or it will increase the upper cervical instability or craniocervical instability, or CCI. So if you have Eagle and CCI, what should you do? Let's say you really are one of those rare people that has both. Well, try to get the CCI addressed first. Normally, most of the time, the Eagle symptoms go away. And that's all that needs to be done. And that's usually in our clinic with that EPICL procedure. If they don't, you can always get a styloidectomy. However, if you get a styloidectomy first and you make the instability worse, in my experience, you are a harder patient to treat. And there's no going back. You can't undo the styloidectomy. So it's better to do the less invasive thing first, something like an EPICL, than the more invasive thing, which would be an open surgery on that styloid. Okay, that's the information for today. Let me get rid of that here. And we will start answering some questions. Happy New Year, Dr. Centeno. Happy New Year, Vero. I was diagnosed with some CCI types after my telemedicine consultation, but other types were suspected. Will those be determined after the physical exam? What's the approach for PICL if some CCI types remain inconclusive? Yeah, that's a very good question, and I think an important one, right? In an ideal world, we would have ideal imaging. We could do all the imaging we wanted to, and we would lock in the CCI types pretty exactly. Problem is, we're not in that world because the DMX is usually a cache type image. Oftentimes, an upper cervical MRI with flexion and extension in an upright setting is also, for many patients, a cache pay image. So most of the time, once we identify craniocervical instability, we then use the hands-on physical exam and the history to infer other types of CCI. So a great example of that one would be a patient who has significant symptoms when they look up. Usually that means we're going to add into the EPICL procedure the anterior AO ligaments, likely because of a CCI type 1C. So we try our best to infer from physical exam the other things that need to be treated. If you only have C1, 2, and C3 through 7 are bone grafts, screws, plates, and fused, could you have CCI and C1, 2? Yes, that's possible. We see that not uncommonly. What I mean by that is we have patients that are fused pretty extensively in the mid to lower cervical spine. They then start getting upper cervical symptoms, and that's because of what's called adjacent segment disease. If you fuse an area, the areas above and below will develop more force and then more wear and tear. And that's called ASD, or adjacent segment disease. So if ASD is happening in the upper cervical spine, we usually treat those patients through an EPICL procedure to tighten down those ligaments as best we can, and then treat those upper neck joints, etc. Now realize at the end of the day, it's pretty important for us to understand, and for the patient to understand, that we're going to be chasing the effects of those fusions probably for the rest of your life. Meaning that that's one of the reasons we generally don't recommend fusions in the neck if we can get away with it, primarily because this is what happens, meaning your lower and mid-cervical fusions are always going to be overloading the upper cervical spine. Can't change that. So this is one of those few instances where we will probably be doing EPICL procedures every couple of years on an ongoing basis, and/or upper cervical injections on an ongoing basis because of this constant overload. Alamein, when should we worry about the head pressure? I'm not quite sure what you mean by worry, meaning head pressure is a common component of lots of different issues. If you mean when should you worry about head pressure related to craniocervical instability, I don't think it's anything different to be worried about than any other symptom of craniocervical instability. I think it needs to be put into the bigger context of what's going on with that patient. And again, the sooner you get appropriate treatment, the better, the longer this lasts. If you have craniocervical instability, in my experience, the harder it gets to treat. D07, small benefit from PICL1, considering second, type 2B per U, had DMX, no upright MRI, prioritizing funds, when and where would cause you as a training physician to decide if more imaging is warranted. Well, if you're struggling with funds, the answer is more imaging is not warranted. And you're basically bringing up exactly what I talked about before. The perfect world, we could get everything imaged. But oftentimes patients are prioritizing, should I use funds for A or B? And we're not in that perfect world. So I wouldn't really prioritize imaging unless there was something strongly suspected that would change the treatment plan, which would be unlikely. Ezra, can you remind us exactly where to find the video on your website to give to your radiologist to help them understand exactly what kind of imaging you need with DMX? It's not on our website. It's on the YouTube channel. Let's see here. So if you go to the YouTube channel, so if you go to the YouTube channel here, at Centeno Home is my channel, and you go to videos, and you just scroll on down, you'll find it. It's right here. Replacing DMX, how to use X-ray DDR to diagnose CCI. You could also just search the channel. So if you just search the channel under DDR, my guess is it's going to come up. There you go, it comes up. So DDR is digital dynamic radiography. So anyway, that's where you find it. I had a whiplash accident in 2019 with a hit to my chin and the back of my head. I felt a choking sensation after that. Could you explain why this would happen and how it could be treated? You know, I can't provide diagnoses online. That's certainly not fair to me, and that's certainly not fair to the patient. I can say that it's not uncommon in whiplash accidents to injure the anterior structures, like the anterior longitudinal ligament, which lives right behind the throat area. or the longus colli or capitis muscles, which also live right behind the throat area. And sometimes that can cause choking sensation. It's also possible that there may have been some injury to cranial nerve 9, which innervates the back of the throat, or cranial nerve 10. Have you ever discussed what brought you to develop the PICL, why you're so passionate about it? You're an amazing doctor. Well, thank you. Yeah, I have a couple of times, but basically the story goes, I, as a young doctor, when I had just come out of residency and started practicing, had a patient who was dizzy, and I was pretty sure they were dizzy from their neck. Now, that's not something I'd ever been taught about in medical school or residency. And I saw a report from an ENG that was done by a local audiologist. So I was trying to meet people in the community. So I just called them up and said, hey, can you explain this report to me? Because the report also seemed to refer to the dizziness coming from the patient's neck. So I struck up a friendship with that audiologist. He was a PhD audiologist, Ed Jacobson, who's now passed away. And Ed really taught me a lot about cervicogenic dizziness coming from the neck. And he started to refer all of the patients that he was seeing who had neck issues and were dizzy, and he thought the dizziness was coming from the neck. And through the years, as I started to develop a bigger and bigger practice of these upper cervical injuries, people with headaches, dizziness, imbalance, etc., we started to see a population that we could treat pretty easily by just injecting those upper cervical structures, and a population that we couldn't manage at all. And then eventually Evan Katz moved to town, and he started doing DMX, and we started noticing that a lot of the patients we couldn't manage had C1, C2 overhang on their DMX, or C1, C2 instability. And it was really after being frustrated for 5 years, looking at those patients, knowing what was wrong, that it was upper cervical instability, but also knowing that we couldn't reach the ligaments that actually stabilized that area. So that's how the PICL got developed by me. Lots of thought went into how we would get there. The only place or the only route that made sense was intraoral, and the rest is history. Greg, is it okay when CCI better with EDS to wear MC helmet? Tried to ride but can't due to comorbid issues like both street and trail riding. Would like the possibility after treating CCI, POTS, MCAS. So I think you're saying a motocross or a motorcycle helmet. Yeah, I would say probably not a great activity for someone with craniocervical instability. I think you'd probably have to strengthen quite a bit in your neck. So I would say if you wanted to try to return to something like that, you would go through the entire rehab program that we have online. You would then go through Todd Ball's program, and you might even try, what's the name of that? I'm blanking on it right now. Gyrostim. So if you were going to get to that level, I would go through a complete gyrostim program. Gyrostim is a machine where you're seated and you're given a little laser pointer and you're hitting various targets as they move you around to get your neck strong enough to tolerate something like that. Now, not all of our patients can go through a complete gyrostim program, so you may or may not get there, but if you wanted to try to, I think you'd have to basically go through that entire program, because in that program, they're turning you sideways, they're turning you upside down. And if your neck is able to tolerate all that, it could probably tolerate what it is you're describing. Julianne, thanks for all your service, doctor. Thank you, Julianne. Tyler, not sure why any doctor would pick the most invasive option to destroy the structural integrity of that area. Much more conservative approach seems better. Stabilize the cervical spine first. Yeah, I would tend to agree that destructive surgical procedures where we're taking parts or pieces out aren't really the best option in most of the cases. And that's something I've been dealing with my whole career, meaning that most spine surgery or head and neck surgery is destructive. And I would agree with you. That's one of the reasons I am one of the fathers, or maybe I'm getting old enough to maybe be one of the grandfathers at this point, of interventional orthobiologics in general, because there had to be a better way. As I was coming through my career, I said, this is a little bit crazy. We're ripping out discs, we're taking out parts and pieces, we're putting in all this hardware. And a lot of these people aren't any better, and some of them are much, much worse, and then they get much, much worse over time. And then we're doing a second surgery and a third surgery, et cetera, et cetera. So ultimately, I would agree with you. It's just part, however, of that surgical approach often means take something out or put something in. Carol Smith Advanced by Harry Winston. If I have been diagnosed with an elongated styloid, but it's not causing an issue that I know of, should we address the CCI first? Yes, I think that's ultimately what we're talking about here, is address the craniocervical instability first before you get an elongated styloid removed, especially if you have no idea as to where the elongated styloid is actually causing your symptoms. Hey guys, do me a favor. Just going to take a quick second here to talk about, give me a like, subscribe, share, etc. That's how people find this video. And if you want other CCI patients to be able to hop on here, ask questions, get their questions answered, please do me a favor and like the video. That will tell the algorithm that this is important information for CCI patients to find. Thank you. JS, if a person has degenerative cervical myelopathy at C3 and C5, CXA at 130, and medulla, low-hanging cervical tonsils, or CTE, what of these issues do you treat first? Well, the CXA is normal. CTE is normal. Just looking at these facts, I would say degenerative cervical myelopathy would probably be the top of my list, but I'd have to know more about what's being described there. Meaning, are we talking about myelopathy causing damage to the spinal cord? Are we talking about maybe just irritation at that level? Because that would determine whether it's surgery or interventional orthobiologics. Or are there other types of instability, for example, that may or may not be present? Low-hanging cerebellar tonsils, or CTE, or KRE0, isn't a problem unless there's something else occurring like upper cervical instability. Happy New Year, JS. Tyler, based on CB, CT, and DMX, I think I have both, but we'll see when we meet. Sounds good. JS, can you say again how we submit scans, diagnosis to you, etc.? Yeah, all of that's done through the Centeno-Schultz website. So let me try to share screen here. So if you go to the Centeno-Schultz website, off on the right here, you'll see specialty areas. Click on that. You'll see craniocervical instability. Click on that. I usually like to go to the second page down, craniocervical instability. It'll ask if you want to download the book on CCI. And then it goes through the steps, step 1, step 2, step 3, step 4. You can click this make an appointment button, and that'll start the process. Okay. After my 2019 whiplash accident, my tongue also began pushing hard and raised the roof of my mouth. Can PICL help, or should I see my orthodontist? Can't really answer that question. I don't know if you've got craniocervical instability. Remember, PICL procedure or the EPICL procedure is to treat craniocervical instability. So if you had craniocervical instability, we certainly see craniocervical instability patients that have tongue problems, usually due to cranial nerve 12 being irritated. So if it were due to craniocervical instability, then that might be the next step, but I don't have that information. I was diagnosed with C1-C2 facet joint through diagnostic blocks without other instability. What are chances of improving with posterior PRP injections? This procedure also covered my C6, 7, L4-5 facet pain. So if there's no instability, then the next step would usually be to inject the C1-C2 joints with PRP. There may be other things causing symptoms as well. So for instance, you might have an irritated greater-occipital nerve that needs to be treated at the same time, so that those things are often comorbid. As far as also treating your C6-7 facet joints, in our clinic, that would be commonly done. We would also treat the posterior ligaments at the same time. As far as your lumbar spine, your L4, L5 facet pain, again, in our clinic, we would probably just treat both the neck and the back at the same time. Kathy, can CCI cause muscle spasms on top of shoulder running up neck into the area of the mastoid temporal bone, below the ear and into the mouth? Feels like sludge in head with pressure pain. It can, yes. We see CCI patients that get quite a bit of tightness in the sternocleidomastoid here, also tightness in the upper trapezius. You can get with the sternocleidomastoid irritation of the superficial cervical plexus, which then causes pain into a couple possible places along in here, down here, and up into the side of the head, very much into that ear area. So you may be describing the effects of a tight sternocleidomastoid muscle irritating the superficial cervical plexus. Tyler loves gyrostim. Yeah, we have one patient that swears by it. She was higher level, or at least we got her to a higher level. But for her, it's really what completed her rehab and got her to the next level. She's probably 95% back to normal now. Having said that, I don't know that most of our patients could tolerate it, but I think for the right patients, it's really good. Greg, motorcycle, mainly street, only light trail if possible. Yeah, Greg, like I said, I think gyrostim would be a great place to get to. And if you could do a gyrostim program, then my sense is you'd be pretty rock solid and bomb-proof, but you'd want to get to the bomb-proof level, which would be higher than most of our patients, simply because of the kind of things that can happen on a bike, even if you're on a light trail wearing a heavy helmet. Now, one of the things I'd probably try to do is get the best, lightest helmet on the market. I don't really know this, but I assume that there are super light helmets that are very structurally sound that you can purchase nowadays versus their traditional heavy motorcycle helmet. Carolyn, I have heard you say that it's typical for patients with CCI to feel better lying down. What might your thoughts be in CCI patients whose symptoms, pain, and headaches increase when lying down? Yeah, that's not everybody that gets better when lying down. If you, I think, maybe correct me if I'm wrong here, Karen, but if what you're saying is that your symptoms when you're resting tend to be worse, then that can come from arthritic joints. We all know grandma and grandpa, right? We remember them with creaky knees, having a hard time getting out of the chair after they've been sitting for a while, but once they got going, they were pretty good. That's arthritic pain. Arthritic pain is hard after you've rested and can get worse as the joints swell when you're resting. But when you're moving about, it tends to be better. So when grandpa or grandma get out of the chair and they start to walk a little bit, they actually were better. So that's more arthritic pain. In this case, it'd be arthritis in the upper neck joints is kind of what I think about when I hear that kind of description. Edgar had good improvement from EPICL number 1 for type 2B and posterior PRP for type 3A. C1 tends to rotate out of place around 45 degrees or so, with C0, C1, or PLL all need to be targeted on next EPICL. When it comes to posterior longitudinal ligament, we can catch that at the tectorial membrane pretty easily with a little bit added risk through the EPICL approach. 0-1 is also easy for us to target, obviously, through an EPICL approach. So that seems to make sense. I have to obviously do an exam and much more analysis, but that seems to make good sense. Keep health, Dr. Centeno, SCM muscles, very sore, stiff, standing, walking, relaxed, laying down. Cause? I don't know specifically what the cause is in you. I can say, though, that craniocervical instability patients, especially C1, C2 instability patients, get a lot of tightness in their sternocleidomastoids. Now, why is that the case? C1, C2 is responsible for about 50% of your neck rotation and is very much linked into the sternocleidomastoid muscle function. So when C1, C2 is putting out abnormal position sense or pain signals because of the instability at C1, C2, that causes the sternocleidomastoids to tighten, all the way up to the point where there's even literature out there that shows that patients who are being diagnosed with cervical dystonia, which would be so much tightness in C1, C2 that their head stays to one side, that issue can sometimes be traced back to a problem at C1, C2. MAS have, or if we have the imaging results, would we still have to come in person to find out if I have CCI, or can it be done with video consultation? Yeah, well, almost always, unless the person is local, we do a telemedicine or a video consultation. So we get all of the imaging. Now, I don't want the reports as much as I want the actual images. We would then have you fill out a very large questionnaire online about craniocervical instability, all the parts and pieces, symptoms, history, etc. We'd want you to submit any history documents that are important as well. And then we review all of that, a video consultation, and can usually get to the person as a candidate for what it is we do, EPICL, advanced posterior injections, etc. And then only at that point would you be green-lit to come into the office and do a hands-on exam and treatment. Karen, are there any injections that can be done around elongated styloid during the EPICL procedure in patients who have overlapping symptoms? Yeah, Karen, we really wouldn't want to do injections at that level. They'd be too dangerous. There's too much there to screw up. Having said that, we often treat the individual nerves through higher dissection at other locations. But ultimately, if someone is getting pressure on that neurovascular bundle, the IJV, cranial nerve 9, cranial nerve 12, the vagus nerve, cranial nerve 10, that's happening because of instability at C1, and the transverse process is banging into that area. So at the end of the day, we want to try to get rid of instability at C1, C2 as the prime mover of getting rid of those symptoms. Or we can also treat the individual nerves at various spots. But right at the styloid, probably not the best place to treat those nerves. Can someone get PICL procedures after a fusion for any symptoms left over or maybe instability they continue to have in other areas of the spine? PICL wouldn't make sense after a fusion because it's controlling the same upper cervical bones as a fusion would control or fuse. Having said that, we do and have treated patients post-fusion for areas of what's called adjacent segment disease. So let's say if you get a C1, C2 fusion, oftentimes the 0-1 joint then gets beat up because of the extra wear and tear there. So we'll be treating the 0-1 joint or the 2-3 joint just below that 1-2 fusion. So that we do, but the PICL component of treating the internal ligaments wouldn't make sense because those are the same ligaments that control the fused bones. Yeah, I'm not answering the next one from someone trolling. If having instability in the neck, can it cause lower back pain and a bulging disc and a pinched nerve? Certainly instability in the neck can cause problems in the low back. We tend to see the transversus abdominis muscle go offline. We tend to see other low back stabilizers go offline in patients with chronic neck issues. So yes, neck problems can secondarily cause low back stability issues. Julie, hi, Dr. C. I was trying to find this answer on the subreddit PICL page. What causes the deep cervical flexor muscles to atrophy? I know instability in facet joints cause bobblehead disequilibrium, but do the atrophied muscles also contribute? You know, Julie, this is an interesting story for me personally because one of our physical therapists back in the day, this is 20 years ago, was Jim Elliott. And Jim, very curious guy. I still remember the day that we had been looking at lumbar MRIs and seeing atrophy of the low back stabilizers, which are just starting to be studied back then and published on. And as we started to look at neck MRIs, we saw the same kind of atrophy happening in the upper neck. And ultimately, Jim ended up going to Australia, getting a PhD on that topic, atrophy in the upper neck muscles. Then now he's at Northwestern in Chicago as a professor there. And he has published about a dozen papers on atrophy of the upper neck muscles. What causes atrophy of the upper neck muscles? No one's 100% sure. It could be traumatic from some trauma. It's probably related to the fact that muscles that move areas that are painful tend to atrophy. And so if you injure the upper neck joints, whether it's through instability or another mechanism, then the muscles shut down because their action becomes painful and the body says, don't do that. So in order to get those muscles back, you both have to get rid of the pain signal, which oftentimes is injecting the upper neck facet joints. And then I obviously have to work on getting those muscles stronger. And as you bring up, those muscles are rich in spindles and position sensors. And so they can cause imbalance, just like the upper neck joints. Nicholas, I had a left side C1 bone shave and styloidectomy. Styloidectomy made my CCI worse and more difficult for AO to work. It detaches vital anterior muscles. Yeah, Nick, that's what we've been talking about here. I've seen that a lot in patients where They basically get a styloidectomy and then their CCI gets worse, or maybe one set of symptoms get better and other symptoms get worse. And that makes sense, right? As we talked about in the 10-minute little lecture I gave today, is that there's an anterior stabilization system. And if you start removing parts and pieces, you'll get more instability, not less instability. I have 1A, 2A, 2B, 3B. Could this explain a choking sensation in tongue that pushes the roof of my mouth? Excuse me, pushes the roof of my mouth after whiplash? Yes, certainly craniocervical instability, as we've talked about, especially when the atlas is unstable, can cause that transverse process of the atlas to irritate the nerves. And in this case, that might be the cranial nerve 9 or cranial nerve 10 and can cause a choking sensation. It also could just be physical or mechanical, because if you if you look at where the back of the throat is, there's not much room there between the back of the throat physically and those bones. In fact, oftentimes in most patients, a centimeter or less. So let's say anywhere from 1/3 of an inch to 1/4 of an inch thickness of tissue. So if you have bones, let's say the atlas or C1, C2, that are pushing literally against and coming forward, and they're pushing against the back of the throat, there just isn't much tissue there. So you can get mechanical choking as well. How would you treat cranial nerve 12? Well, if it's getting irritated through the CCI, the first thing to treat is the CCI. Nicholas, I have left stents that have damaged left jugular. Do jugular decompression. Sorry, guys, I'm going to take a drink. Do jugular decompression surgery make CCI worse? Yeah, so the jugular decompression we're talking about here is usually styloidectomy or C1 shaving, both of which take out parts and pieces that stabilize the upper cervical spine. So if you have craniocervical instability and you start removing those structures to decompress the jugular, then yes, that can make CCI worse. Now, it sounds like you're in a pretty unique situation. I've only seen one other patient from the UK who had a fairly damaged IJV. They stented it, and then they put another stent within a stent, and then that got clogged, and it was a real mess. So you're in a very unique clinical situation, and so you've got to be very careful about which direction you go next. If you have fusions in cervical spine, C3, C7, can it cause back pain, bulging disc, and pinched nerve? Not usually. It's probably more common, though, that chronic neck pain can lead to problems stabilizing the low back, or sometimes they're just comorbid, meaning there's just problems in the neck and the back. But it's unlikely your fusions are making your back worse. More likely that just chronic neck pain is making your back worse. Cindy had PICL 4 years ago by you. I'm coming again in 2 weeks. I have occipital neuralgia with other neurological symptoms. I've had fusion at C5 through 7. I've carried 0 as a chance for healing. You know, Cindy, I have to take a look at everything else again. Usually with PICL, those procedures should be done in a sequence of every 3 to 6 months. Usually it's 4 to 6 months practically. And that's how that process works. So we'll just have to see where you are at this point and what's going on. A fusion in the lower neck doesn't help, right? Because that then takes and pushes additional forces above the fusion level. And what's above the fusion level is, in fact, the upper cervical spine. So I'll have to take a look and see. Mark, what is the best image to help eliminate corpus callosum damage from CCI due to whiplash injuries? Well, that's an interesting one to unpack. I don't know how to answer that because craniocervical instability wouldn't necessarily cause damage to the corpus callosum in the brain. And so it's a hard one to answer because it's kind of a non sequitur there, meaning one doesn't follow the other. So it's unanswerable based on that does not follow principle. For C1C2 posterior fasted PRP injections, maybe fasted is not the right word there. To what extent does it cover the most important aspect of the capsule? I know it can't cover all parts of it. So maybe the best way to answer this is to talk about the different and various levels of injections here. And this is where patients get scammed all the time, day in, day out. So this is a really important one to listen to. At the end of the day, there are providers out there who would claim to inject C1C2, but they're really just putting the needle in the vicinity of C1C2, and they're just doing simple, either blind or ultrasound guided injections at the back of that upper neck bone area. Then a substantial leap above that in training would be someone who uses serum fluoroscopy and contrast confirmation to get into the C1C2 facet joint, and also has digital subtraction angiography to make sure they don't stroke out the patient by inadvertently injecting the vertebral artery. The first kind of provider frequently claims they're injecting the, quote, facet capsules, but they're really not. They don't have any idea where they're injecting other than they're injecting against a bone in that vicinity. So the facet capsule thing kind of starts with a little bit of a fit to the patient, meaning if I'm the provider that's doing that simple injection, I don't have any clue what it is I'm injecting. I'm going to call it facet capsule because that'll make you feel better. But at the end of the day, I don't really know because I don't have any guidance and I don't have the right kind of guidance. Now, in the second kind of injection we talked about, where the provider is much more highly trained and they're using X-ray guidance and contrast confirmation and digital subtraction angiography, now I know I'm in the joint and I can inject the facet capsule on the way out very easily. So I think you're getting maybe confused by a provider that told you they were injecting the facet capsules, which is usually a euphemism for, I don't have a clue with what I'm doing here, but I'm going to stick the needle in that vicinity, which is not something I would recommend at C1C2. Vivek, what does the new tissue look like that's strengthening the ligaments after PICL? Vivek, I don't think we can answer that question because it would require sacrificing, obviously, the patient and doing a biopsy of that tissue. If you didn't sacrifice the patient, it would be a very dangerous surgery to get the answer. So obviously that's not going to happen. And imaging of this area isn't all that great. Now, in other ligaments where we can image the area with much more accuracy, like the ACL, we've published 3 or 4 different papers on that. And we see MRIs consistent with healing of the ligament when bone marrow concentrate is injected into the ligament. And then there's one study in the Achilles where they could easily do a post-op biopsy using platelet-rich plasma, which is what we're injecting with bone marrow concentrate, that showed actual improvement in the histology of the tissue when PRP was injected. So that's probably the best answer I can give you at this point, because obviously no one can sacrifice themselves to give that tissue sample. And even getting the tissue sample and keeping the patient alive would be extremely risky. So just not something that's going to happen anytime soon. Edgar, after EPICL number 1 and posterior PRP improvements, have developed some rotation left to right symptoms on occipital tissue attachment at the base of the skull with sudden movement. What could cause this? Sounds like you're describing maybe pain that occurs right where the muscle attaches at the base of the skull, one of the suboccipital muscles. So I'd have to do a hands-on physical exam, but it might just be some tendinopathy there, meaning all muscles have tendons that attach to bone, and that can then lead to pain at that area. So oftentimes we have to treat that tendon directly. I do want to say something real quick here. We had a kind of a trolling guy on here today. One of the issues with the pro bono program is, and just let me go backwards here. The EPICL pro bono program is where we offer 12 to 14 slots per year for patients that are at destitute levels. And some of those come from the third world rather than the first industrialized world. And that's all good. We've had patients that we've considered from the third world. One of the things we won't consider, though, for that is we're not going to burn a slot on someone who might have problems coming into the country because of that country's status with U.S. immigration. And right now, as you know, in our current administration, there are countries that it's very hard to get a visa to come into the United States. And we're just not going to prioritize that kind of patient from that kind of country because the likelihood that we maybe get the person here is small. So we burnt the slot and they can't show up. And so that means that that slot could have gone to someone who could easily get here. Or maybe we get the first one done and then we go to a second one. We can't get that done because we can't get the person in the country and we burned a slot there. So I'm just not going to do that. I'm not going to burn one of those valuable EPICL pro bono free slots on a situation where we can't easily get that person into the country for treatment because of that country's status with U.S. immigration and customs. So that's what all that stuff was about. It has nothing to do with anybody's race or et cetera. It has to do with the practicality of getting that person in here and taking a slot away from someone who is equally deserving, who can easily get in and out of the country without any problems. Alex, feeling a little more unstable coming up in 8 weeks post-PICL. What's the mechanism behind that? Yeah, Alex, sounds like the donut hole. The donut hole, if you just go on to my YouTube channel and search donut, it'll come up. And basically what happens there is for the first couple of weeks, patients see a stabilization effect from the swelling of the ligaments. And in fact, I just experienced this myself. My right knee is unstable, right? And it's been unstable for a little bit. I just haven't had time to get it treated. You know, as my mother used to say, the carpenter's son has no shoes. I could have gotten my right knee treated dozens of times, but there was always something else going on, so I just didn't do it. And so I finally had the ligaments injected. We just did some simple prolo into the ligaments. I'm going to do some PRP this next week into the joint. But it was amazing for the first 5-6 days how good it felt and how stable it felt. And then now, as that swelling is coming down, which is reducing the tightening of those loose ligaments, now it's starting to do some of the same stuff it was doing before, and it will take a while, with prolo usually 3 to 6 weeks, to tighten back up again. Now, for something like an EPICL, same thing with bone marrow, but the swelling is going to last a little longer, and then you're going to have the donut hole, where it kind of goes back to normal, or it feels a little worse relative to how well it felt during those first couple of weeks. And then it's going to start to get better as the tissue gets laid down and remodels. So that's what that donut hole is about. Shannon, do you suggest a spinal cord stimulator with CCI, or what would be the best treatment? No, definitely not. Spinal cord stimulator would not be a valid way to treat craniocervical instability. The best treatment depends on the CCI type. So we type the CCI, and that then maps to a specific treatment. So the first thing you need is movement-based imaging. The second thing would be typing. The third thing would be then we can assign a treatment that's injection-based usually. Now, some people are beyond that. They go directly to surgery, but movement-based imaging, typing, treatment, that's the way that needs to go. Ronald, dear doctor, if a patient has vascular Eagle syndrome and confirmed CCI, can the vascular Eagle syndrome improve with PICL treatment? Is styloidectomy likely necessary sooner or later? Yeah, most of our patients in that category, Ron, end up not getting any type of decompression surgery for Eagle syndrome. The Eagle type symptoms go away. As I've said before, it's something where you can always get a styloidectomy done if you need to. We really don't need to start there first. So, hey, Nick. Yeah, I don't know anyone's name on here, so thank you for bringing that up, that you're the patient that I'm talking about, so thank you. Alex, eye flutters, eye misalignments, eye doctors, including neuro eye docs, said eyes healthy. Did say I have BVD, binocular convergence disorder maybe, and prescribed prisms, but haven't tried them yet. Should I try them while I'm healing? Yeah, Alex, that's something to talk to your treating doctor about. We definitely recommend vision therapy for some patients during their rehab post EPICL, but I talk specifically to your treating doctor who will know more of your history. Kathy, it's okay to use a TENS unit for muscle spasms in shoulder and neck. I have instability at C3-4, 6-7, along with pinched nerves. Yeah, Kathy, TENS units would be commonly used in patients with chronic neck pain. So I don't think there's any concern there. Obviously, I don't know your specific history, and I don't have enough information there to make any kind of clinical recommendation. But TENS units are frequently used in patients who have chronic neck pain. Jane, I became more unstable after styloidectomy. Unfortunately, I learned later that the 2 ligaments were removed on each side of my neck when the styloid process was cut off. That's how I understand it anyway. I can't seem to get any neurosurgeons to understand that I suffer from CCI. Only my chiropractor understands and treats me. Yet it's a circular cycle that will never end. By seeing my chiropractor temporarily fix my CCI, relieving that pressure off my brainstem, why aren't there more maybe MDs who understand all of this? Yeah, it's a good question. Why aren't there more MDs who understand all of this? Listen, Jane, I think we have the surgical approach, which is the surgical approach, right? That's what those guys can offer. And as surgeons get better and better and more knowledgeable, they tend to realize that there are other options outside of what they offer, just like I realize that there are other options outside of what I offer, meaning that I routinely refer patients, for example, to Dr. Henderson when we can't handle the type of CCI they have. But you bring up a good point, right? At the end of the day, you're describing exactly what we see patients experience when they've had a styloidectomy and CCI, and it then starts a vicious cycle because the instability gets worse, and then they need to constantly do something to stay in place. So thank you for bringing that up because it's exactly what we're talking about this morning. Finnegan, do you think water therapy to help support the weight of the neck is useful for early stages of rehab for CCI? That's a hard one, Finnegan, because, if you think about it, to really take the weight off the neck, you'd probably have to get submerged to about here. Now, I guess you could do it with a snorkel, and in the right pool, that might work, but the snorkel may also mess with the person too. So just would be a hard one for water therapy, because ultimately submerging yourself enough to take the weight off the head is going to be a difficult thing to pull off. Brett, how rare is it for CCI to actually cause death? Even the most severe cases you've treated, what are the real odds? Because so many of us live with symptoms generally make us feel like we're dying every single day. It would help separate what feels like terrifying from what's actually dangerous. Brett, I don't think I've had a single patient in, well, let's just go back to the PICL days. That's 10 years. If we go back to even further to when I first started treating CCI patients about 25 years ago, I haven't seen a single person die from CCI. Now, certainly you can feel like that. And there are patients who get craniocervical instability in huge car crashes where their head's falling off, and they do need emergency surgery to survive. But those people are fairly easy to diagnose and separate out in the emergency room. So at the end of the day, the answer to your question is it's extremely rare. So rare, I haven't seen one yet. And I've treated thousands and thousands of craniocervical instability patients in the last 25 years. So I think it's important to recognize that you're probably not going to die from this, but it can make people feel really, really miserable. And I want to recognize that for sure. Hi, regarding hyoid bone syndrome, is it the same problem as with Eagles concerning surgery and CCI? Yeah, so it's the same issue. If you're going to get an operation on the hyoid bone where parts and pieces are cut out, important muscles anchor there, and those muscles are part of that anterior stabilization system. So you're going to be destabilizing the anterior stabilization system of the neck. Vivek, thank you, Vivek. Appreciate it. Karen, getting ready to book my EPICL for March. Hopeful to begin this next phase of healing potential. Thanks to you. Excited to meet you. Thank you for all you do. Karen, looking forward to meet you as well. Jane Ann, where can I get movement-based imaging and learn what type of CCI I have? I've had a DMX from Swedish Hospital in Denver. Definitely wasn't a DMX from Swedish, paid by my insurance, but it didn't come with any measurements. I live in Northern Cal. Yeah, Joanne, so definitely did not get a DMX from a hospital. Those aren't in hospitals. So I think you instead may be talking about simple flexion extension x-rays, which is not a DMX. Joanne, I think the best place to start learning about all of this would probably be either going to my YouTube channel, which I shared before, or going to the Reddit sub, RPICL. I'll share that here. Let me share that. So on Reddit, this subreddit, RPICL, is a great place to go. There are just, I don't know how many at this point. There are probably 1,000 or more posts here from different patients, from me every day. I think I'm like at 400 posts for 400 straight days here. I answer questions on here usually 3 to 10 times a day. And so this is a great place to start learning about all of this, as well as the YouTube channel. And then obviously I've already shown our website is here, Centeno-Schultz. There's a whole section on craniocervical instability. You can actually download a whole book on craniocervical instability here. And then here is my YouTube channel, and you can learn a lot there as well. Let me stop that share here. Hey, Dr. C, how can I get out of fight or flight state? Is my vagus nerve irritated? I still feel unbalanced, but I have improved, maybe. I've been holding the last 6 weeks. Thank you for all you do. Yeah, Kevin. So at the end of the day, if it's due to vagus nerve irritation, then for the right types of CCI, we would use that EPICL procedure plus higher dissection of the vagus nerve, and that usually works. There are also vagus nerve stimulators out there, like Truvaga is one, and there are even physical therapists, like IPA Physical Therapy, where they have some of their specialists nationally that do physical therapy on the vagus nerve. So lots of different options there. Angela, what are your thoughts on using the Saunders traction device at home in conjunction with my PT? I have severe bilateral jugular compression at C1, but small styloids. Usually axial traction, Angela, wouldn't be the thing to do if you had jugular vein compression happening due to the upper cervical spine. Joanne, any type of over-the-door traction that I recommend? Yeah, over-the-door traction is inexpensive, but can be a little hard to control. I think you may want to try traction in a physical therapy office at the direct supervision of the physical therapist, who could then see if you're a responder to that type of treatment. And then from there, they can prescribe a unit to use. But I think I'd try it in a controlled setting first. Jaweed, how can I diagnose AO instability if there's no movement-based upright MRI available? Yeah, Jaweed, I think we've already covered that. So if you go back to, let me share the screen again here. Go back to the YouTube channel here, my YouTube channel at Centeno Home, and you just type in DDR into the search bar here. This one will come up, replacing DMX, how to use X-ray DDR to diagnose CCI. That would probably be your best bet. Jane, what's the difference between PICL and EPICL? EPICL is just a much more advanced version of the procedure. I would say a more perfected version of the procedure that's dramatically better than the first version, which was PICL. Okay, let's see. Okay, guys, well, I think we're at an hour and 15 or approaching that. I know I've still got questions coming in, but I also have some stuff to do today. As I said, I'm working on the data set analysis from the upcoming paper, and I want to get to that. I want to get back to that. Okay, guys, well, thank you so much for watching today. Thanks for all the great questions. As I always say, we all learn when a great question comes through. It's a great way for patients who, obviously the person the person asking the question gets information back, but we all do, right? We all learn when a really good question comes through. So thanks for the questions. I'll be here again, I believe, next weekend, although I may not. I'll be traveling in and out of San Diego, so I'm not quite sure if I'll be back in time. I'll have to check. So I may try to do next week's Facebook Live on like a Thursday evening rather than Sunday, just because of the practical realities of travel this next weekend. So have a great week. Happy New Year. And I'll either see you on Thursday or Sunday. I'll figure that out during the week for another one of these Q&A sessions. Thank you.